It's my pleasure and honor to introduce the second speaker, which is Qiang Lu, and the presentation is about the role of contrast-enhanced ultrasound for the diagnosis of liver metastases.
Thank you for Adrian for the chairman's introduction. It's my honor to share with you my experience of contrast-enhanced ultrasound in patients with liver metastases. And we have listened to Professor Zhao's lecture about the primary cancer of the liver. So we'll talk about secondary liver cancers. And my presentation mainly focused on the following three parts: introduction of liver metastasis, application of contrast-enhanced ultrasound in liver metastasis, and conclusion. With the aging of the population, the development, application, and screening and diagnostic tools, the cancer incidence increases in the past several decades due to its abundant blood supply and unique portal venous circulation. Liver is one of the most frequent sites of metastasis for a rare type of cancer. It is reported that the liver metastasis has 18 to 14 times more common than the primary liver cancers. Take the colorectal cancer, for example. About 15 to 25% of cases have liver metastasis at the time of diagnosis, and another 15 to 25% cases will develop liver metastasis even after curative resection. And that is to say, up to about 50% of the patients will have liver metastasis during the whole disease process. Generally speaking, the prognosis of patients with liver metastasis is poor. So the detection and the characterization of liver metastasis is important. The GI system is the most common site of primary malignancy, including the colorectal carcinoma, pancreatic ductal adenocarcinoma, gastric carcinoma, gastrointestinal stroma tumors, and neuroendocrine tumors, followed by breast cancer, lung cancer, genital urinary system tumors, melanoma, etc. Not all the liver metastases have the same imaging appearances. Some of them are often presented as a hypoechoic mass, that is about 25% of the cases, such as lung cancer, breast cancer, pancreatic cancer. Some of them were presented as a hyperechoic mass, such as colorectal cancer, renal cell carcinoma, etc. Calcification is more common found in mucinous adenocarcinoma. Some can cause cystic liver metastasis, even though the primary tumor is solid, such as ovarian cancer, pancreatic, neuroendocrine tumor, and GIST. In contrast-enhanced study, liver metastasis may be divided into hypervascular and hypovascular. Hypervascular tumor may show partial or total enhancement during the arterial phase, such as the breast carcinoma, renal cell carcinoma, and melanoma. To better understand the contrast-enhanced ultrasound features of liver metastasis, let's review the main pathologic changes. First of all, the liver metastasis is supplied by hepatic artery and absence of portal vein. That is the reason for the washouts in portal vein. port vein phase, especially in some cases, very early washout. Second, desmoplastic reaction, inflammatory cell infiltration, and vascular proliferation were found in the perineal area. High microvascular density in this area corresponds to the ring-like hyperenhancement of the liver metastasis. Third, in the central area of the liver metastasis, may found desmoplastic reaction and coagulative necrosis. This is why, in some cases, we found less or no enhancement in the central area of liver metastasis. Imaging plays a very vital role, very important role in the field of liver metastasis. Contrast-enhanced ultrasound is one of the most commonly used contrast-enhanced imaging methods. It could be used as a screening tool, including the application during surgery, and differential diagnostic tool for liver metastasis and other focal liver lesions. And it could be used also to evaluate the interventional procedures such as biopsy and ablation. In a system review, solid view enhanced contrast-enhanced ultrasound could provide similar diagnostic performance to other imaging modalities for the assessment of focal liver lesions. And in the same study, it was reported that compared with contrast-enhanced CT, contrast-enhanced ultrasound have similar costs and effects for the detection of liver metastasis from colorectal carcinoma. In patients with colorectal carcinoma, 20 to 30% have liver metastasis, and 10 to 40% of them are too small for clear palpation during surgery, let alone at the age of laparoscopic surgery. The surgeons cannot touch them. So compared with preoperative CT or MI and even conventional intraoperative ultrasound, contrast-enhanced intraoperative ultrasound provides the highest sensitivity and accuracy. In this case, we can see a 4 millimeter liver metastasis detected by contrast-enhanced intraoperative ultrasound. Very small. Then this lesion even missed by the conventional intraoperative ultrasound. So contrast-enhanced intraoperative ultrasound is an essential tool prior to liver resection for metastasis and has the potential to be routinely used in the liver resection of colorectal carcinoma patients. Contrast-enhanced ultrasound is also accurate in differential diagnosis of liver metastasis. In this case, in a 61-year-old male patient, a hyperechoic nodule varying 1.5 centimeters in segment 8, which is homogeneously hyperenhanced in arterial phase. An early washout was detected within 60 seconds. The lesion was diagnosed as liver metastasis by contrast-enhanced ultrasound and proved to be colorectal carcinoma metastasis by pathology. Here we have another case of hyperechoic focal liver lesion in a 44-year-old old lady. The lesions were detected in a routine workup of thyroid cancer surgery. Are they hepatic metastasis? No. Both nodules are homogeneously hyperenhanced in arterial phase. and the enhancement persists during the portal and late phase, and we found no washout in the late phase. So we diagnosed, we think this lesion is benign and diagnosed angiomyolipoma, not a liver metastasis of this case, and was approved by pathology. The contrast-enhanced ultrasound manifestations of liver metastasis varies from primary tumor. Hypervascular tumors are more likely to show global hyperenhancement in the arterial phase, like in this melanoma case, liver metastasis from a melanoma, and breast cancer in this case. Hypovascular tumors are more likely to show donut sign, a thick-walled ring-like hyperenhancement in the arterial phase. Like in this case is a liver metastasis from a pancreatic cancer. And it's worthy to point out that early washout could be observed as a typical feature for metastasis in both hypervascular or hypovascular liver metastasis. In some cases, the washout could be as early as in the late arterial phase. This could be easily evaluated by contrast-enhanced ultrasound because it has a base temporal resolution. Early washout could be also used as an important feature for the differential diagnosis of liver metastasis from other primary liver malignancies, especially hepatocellular carcinoma. In typical hepatocellular carcinoma, the washout should be late and mild. In some cases, however, the differential diagnosis is challenging, such as intrahepatic cholangiocarcinoma. It may also show early and marked washout. Patient's information, such as disease history, serum biomarkers, may help the differential diagnosis. And ultrasound-guided biopsy, which mentioned before by Professor Zhao, is helpful for the differential diagnosis too. In case of ultrasound-guided biopsy, contrast-enhanced ultrasound could provide important information, such as the presence of necrosis, selection of the right target to puncture. In this case, a 44-year-old lady, 10 months after colorectal carcinoma surgery, multiple lesions were detected in the lung and liver. And the contrast-enhanced ultrasound showed a massive necrosis in the hepatic mass. Then the biopsy is carried out and avoid the lung-enhanced area and obtained lung necrotic specimen and proved by pathology the colorectal liver metastasis. So in conclusion, contrast-enhanced ultrasound is an essential tool for the detection, diagnosis, and evaluation of liver metastases. And arterial phase hyperenhancement and early washout is the main contrast-enhanced ultrasound features of liver metastases. Thank you for your attention.
Thank you very much. I'm not sure if there are questions. There is one, but it's in Chinese, so you'll have to check it and answer. Otherwise, I can also ask a question. It was an excellent presentation. Congratulations. Really nice images. Are you doing contrast for all the patients with a suspicion of metastasis, or for all the oncological patients, or not? How do you proceed with the patients? Are you waiting for CT when you are following up, or are you doing contrast directly? contrast enhanced ultrasound, CEUS?
So in patients with colorectal carcinoma, before surgery, we almost routinely do the contrast enhanced ultrasound for those patients. And for patients receiving consecutive therapies, oncologist, patients referred by the oncologist. So, and the contrast enhanced ultrasound is not routinely used for the evaluation of therapy response in our hospital. But we have noticed some researchers are doing imaging fusion of the contrast enhanced ultrasound and the CT to follow up not only the size of the tumor, but also the perfusion of the tumor.
Okay, thank you very much. And for pancreatic cancer patients, do you have the same approach?
For the pancreatic, for the patients with pancreatic tumor carcinoma, we do routinely evaluate the patients with before they were sent to us for biopsy. We'll search for if there are any liver metastases, which is a safer way for the biopsy. So we not routinely screen liver metastasis from the pancreatic patients in our institute. Some of the patients we do the contrast enhanced study.
Okay. There's another question in the chat. What is the accuracy of contrast enhanced intraoperative ultrasound for colorectal liver metastases in your experience? Are you doing EOS, and what's the accuracy?
Yeah, I did some of the cases in the operation room, and I think contrast enhanced intraoperative ultrasound has the highest accuracy among other imaging modalities, and almost near 100%. So in some cases, this method, contrast enhanced intraoperative ultrasound, has been taken as the gold standard to do this research. So when we find a suspicious nodules by conventional intraoperative ultrasound, then we will carry out some contrast enhanced study in some cases. But it is not routinely carried out in our hospital. We do intraoperative ultrasounds routinely, but in some selected cases, we do contrast enhanced study because of the short of hands, not by limited by the value of this method. I think if we have plenty of hands, we want to carry out this method routinely in colorectal patients with suspected liver metastasis.
Okay, thank you very much. There's one more question. Is it with the Sonazoid or with Sonoview? Your experience in intraoperative ultrasound?
In our hospital, we use Soloview. Maybe we'll try Sonazoid in the near future.
Okay. Okay, thank you very much. If there are no other questions, thank you very much one more time. Excellent presentation, I have to say.